Welcome, and thank you for joining us for today's webinar. My name is Jennifer Schaefer, and I will be your WebEx technical support host. Before we dive into today's meeting, I wanted to provide a few quick information and tips on the webinar platform. All lines have been muted on entry and will remain muted for the duration of the webinar. If you have any questions throughout today's presentations, please submit them in the chat or Q&A panel and select all panelists. A moderator will be asking them on your behalf during the Q&A portion. Please feel free to submit them during each speaker's presentation versus holding them until the end. If you do not see the chat or Q&A panel, please find the lower WebEx bar at the bottom of your screen and select the appropriate icons, also labeled. We offer closed captioning for today's webinar, and you can view that via the multimedia viewer in your WebEx screen. We wanted to note that today's webinar is also being recorded and will be available online at a later date. And with that, I would like to turn it over to Amanda to open us up for today's presentation.
Hi, welcome to the Achieving Equity in Cancer Pain Management webinar series. My name is Amanda Acevedo. I'm a Cancer Research Training Award postdoctoral fellow in the Basic Biobehavioral and Psychological Sciences branch at NCI. We're so excited for this fourth installment of the series, and I'd like to provide some background about this series before we introduce our speakers today. In December of 2019, the cognitive, affective, and social processes, oh, it's telling me that there's a crash. Can you guys still hear me?
Yes, we can still hear you, Amanda.
Okay, great. I'll continue then. So the Cognitive, Affective, and Social Processes in Health Research Interest Group, or CASPR, hosted a meeting on cancer pain management disparities at the National Cancer Institute. During that meeting, it became clear that bridging the divide between basic and applied research in the cross-cutting transdisciplinary area of cancer pain management disparities would require more time and tangible forums to foster. Soon after the conference, the COVID-19 pandemic and continued instances of police brutality made it all the more important for researchers to put more effort into studying health inequities and the various ways in which institutionalized racism contributes to these inequities. To that end, my co-moderator, Dr. Rebecca Ferrer, along with Sandra Mitchell, and members of the CASPR group, Drs. Jamie Arndt and Angela Bryan, planned this webinar series to delve into the complex ways in which inequities in cancer pain management arise. For this fourth webinar in our series, we have 3 speakers and 1 discussant here to discuss psychological barriers to equitable cancer pain assessment and management. Specifically, they will discuss how the inherent uncertainties in the evaluation of cancer pain open the window for attitudes and biases to influence the accurate assessment of pain, and will highlight the importance of examining the complex nonverbal dynamics that occur during patient-provider interactions, particularly when symptoms are being evaluated. Our first speaker, Dr. Hagiwara, is an associate professor of psychology at Virginia Commonwealth University and is one of the leading researchers in the field of healthcare provider bias and racial disparities in healthcare and health. With training background in basic experimental social psychology, she grounds her applied disparities research in social psychology theories of stereotyping, prejudice, and discrimination. To date, she has obtained multiple NIH grants on provider implicit bias and published over 45 peer-reviewed journal articles and book chapters. Her recent work on provider implicit bias has appeared in flagship journals, including The Lancet, and also been featured in scientific magazines such as Scientific American and the American Psychological Association's Office magazine Monitor. Without further ado, Dr. Hagiwara will share her expertise with us in her talk titled Cancer Pain Management Disparities, the Potential Role of Provider Bias.
That I'm sharing?
Yes, we can see your screen.
Great, thank you. Okay, I'd like to start my talk today by acknowledging my collaborators. And I also want to give a special shout out to Dr. Greens and the panelists to keep pushing me to challenge my research boundaries. Can't move my, there you go. Is it moving?
I still see your acknowledgement
There you
slide.
go.
Oh, there we go.
Okay, sorry about that. All right, uncertainties are inherent in the evaluation and management of cancer pain. And the social psychology research has consistently shown that uncertainties can actually encourage the expression of individual bias. Let's take a look at these two medical students who are preparing for the match. The Black student is clearly a stronger candidate than the white student. There is no uncertainty in this case, and it is highly unlikely that the selection committee would choose the white student, even if some of its members were racist. But what if the two students are equally strong? This is a highly ambiguous situation, and there is no clear right answer. With such uncertainty, biased selection committee members can focus on the strengths of the white student while focusing on the weaknesses of the Black student. This way, members can justify a decision to select the white student over the Black student, for example, by emphasizing the importance of M2 clinical grades over publications. Therefore, uncertainties often enable individuals to justify their potentially discriminatory behavior in a non-discriminatory manner. The role of uncertainties in the expression of bias is directly applicable to the context of clinical care. That is, healthcare providers' bias is likely to manifest when dealing with diseases with uncertainties or with no clear treatment guidelines. In general, the magnitude of racial treatment disparities are smaller for diseases with clear and well-accepted standard treatment guidelines as compared to diseases with no standard treatment guidelines. In fact, few standard guidelines exist for treating pain. Pain is also often diffuse and non-specific, and is better conceptualized as an illness, which is a subjective feeling and experience of unhealth, as opposed to a disease, which is something that we can objectively see, touch, and feel. Because pain is full of uncertainties, provider's bias is likely to manifest when treating pain. Before I jump into discussing how healthcare providers' bias manifests in pain evaluation and management, I want to clarify the definitions of bias because some of the definitions used in the health and healthcare disparities research are inaccurate. First, there are three elements of bias: stereotypes, prejudice, and discrimination. All these three elements of bias can operate at two different levels: controlled and automatic levels. Bias at the controlled level is an explicit process that is deliberate, reflective, and effortful. On the other hand, bias at the automatic level is an implicit process that is effortless, habitual, and spontaneous. Unlike the popular definition of implicit bias, being unaware or being unconscious is not part of the definition of implicit process. So I have prepared a quick activity for the audience to experience the difference between automatic and controlled processing. This is called the Stroop test. This test is designed only for people who can differentiate colors, so please pardon me for not using activity that's more inclusive. On the next slide, you will see a series of words in different colors. And your task is to say aloud a color in which each word appears as quickly and accurately as possible. You will see multiple columns and multiple rows. So I would like you to name colors from the top row, left to right, then move on to the next row, left to right, and then next row, left to right, and so on. For you to be able to experience what automatic and controlled processing is like, if it's possible, I encourage everyone to say aloud the color of each word. Okay, ready? 3, 2, 1, go. I believe that the task was awkward and somewhat difficult for many of the audience. This is because when words and colors are presented simultaneously, our automatic response is to read. Paying attention to colors is a secondary response. So we have to inhibit our automatic process, reading words, and then replace it with our controlled process, naming colors. The distinction between controlled and automatic processing is also applicable to the 3 elements of bias. That is, implicit stereotyping, prejudice, and discrimination are rather spontaneously activated, and they are harder to regulate than explicit stereotyping, prejudice, and discrimination. But just like the Stroop test, it is not impossible to regulate implicit stereotyping, prejudice, and discrimination. We just need to engage in effortful and deliberate regulation of those biases, at least initially, until the new non-biased responses become automatic. Now that the distinctions among the 3 elements of bias and between controlled and automatic processing are clear, I will next talk about what we know about the role of provider bias in racial healthcare disparities. The recent literature review that my colleagues and I conducted suggests that bias among healthcare providers mainly manifests in 2 aspects of patient care: clinical recommendations and patient-provider communication. Specifically, explicit stereotypes are associated with clinical recommendations, which in turn can impact patient health. For example, one study has shown that providers are just like other people. They hold, or at least are aware of societal negative stereotypes about racial and ethnic minorities, such as minority patients are less educated and are less likely to adhere to treatment recommendations. Importantly, some negative stereotypes are associated with providers' treatment recommendations. For example, providers and trainees who falsely believe that Black people are biologically different from white people were less likely to be accurate in treatment recommendations for Black patients. Our review also revealed that implicit prejudice is associated with the quality of patient-provider communication, which can also impact patient health through patient-centered outcomes such as adherence and care utilization. Our review suggests that Black patients who interact with doctors with higher as opposed to lower levels of implicit prejudice tend to report that their doctors treat them with less respect and that their doctors are less patient-centered. Independent coders also rate the quality of patient-provider communication more negatively for doctors with higher levels of implicit prejudice. This clearly suggests that doctors' implicit prejudice manifest in their communication behaviors during the medical interactions. It is well documented in social psychology that implicit prejudice is generally associated with spontaneous behaviors, such as nonverbal and paraverbal behaviors. That is how we use our body and how we deliver our speech, as opposed to verbal behaviors or what we actually say. Consistently, in the context of medical interactions, providers' implicit prejudice has been associated with a number of different nonverbal and paraverbal behaviors listed here. In sum, at least explicit stereotypes and implicit prejudice among healthcare providers contribute to disparities in the quality of healthcare. The next question then is how provider bias might contribute to the disparities, specifically in the context of cancer pain. Stereotypes are specific to each social group, so I'm going to focus on Black people for this example. One common stereotype about Black people is that Black people don't feel pain as much as white people, which might be at least partially driven by perceptual bias, as Dr. Mende-Siedlecki will discuss next. This stereotype can result in underdiagnosis and undertreatment of pain experienced by Black people. In fact, these false stereotypes justify the J. Marion Sims medical experiment on enslaved Black women without anesthesia 150 years ago. Another common stereotype is that Black people are prone to opioid use, abuse, and addiction. Likewise, Black people are also seen as less adherent, which may lead providers to worry about potential opioid misuse. These false negative stereotypes are likely to discourage providers from treating Black patients' pain with medication. For example, Dr. Moore, pictured here, who died from COVID, said her white doctor made her feel like she was a drug addict when she was experiencing horrible pain in her neck, and he refused to treat her pain. In sum, it is likely that providers who endorse these negative stereotypes are more likely to underdiagnose and undertreat cancer pain experienced by Black patients. The quality of patient-provider communication also matters in cancer pain management because successful pain management requires negotiation between a patient and a provider. Additionally, pain is an emotional and a stressful topic. Productive patient-provider communication plays an essential role in reducing anxiety and stress experienced by patients. Finally, productive patient-provider communication also enhances exchanges of accurate information, which is crucial for making more precise evaluation of pain, as well as for selecting treatment that addresses not only patients' clinical needs, but also personal preferences. Taken together, findings from prior research suggest providers' explicit stereotypes about Black people are likely to result in underdiagnosis of cancer pain experienced by Black patients, while providers' implicit prejudice is likely to result in less positive patient-provider communication, both of which in turn lead to suboptimal management of cancer pain. I will conclude my talk by reviewing severe limitations with the currently most popular approach to addressing individual bias among healthcare providers, implicit bias training. Implicit bias training used in the medical context is typically didactic, and it focuses on educating attendees what implicit bias is and how it could impact their patient care. Although training varies in frequency and duration, it is generally delivered at a single time point that lasts only for an hour or two. Finally, the effectiveness of implicit bias training is often assessed with self-reflections or changes in IAT scores between pre and post-training. The development and implementation of effective implicit bias training should be understood within the clinical and translational science framework, which consists of 5 stages. Of the 5 stages, T1 to T3 are particularly relevant to implicit bias training. In this context, T1, which is translation to humans, is often done in the field of experimental social psychology. The goal of this stage is to identify strategies driven by theories to reduce implicit bias in general populations. T2, which is translation to patients, aims to develop implicit bias training on the basis of findings from T1 and to test its effectiveness specifically with healthcare providers. Finally, the goals of T3, which is translation to practice, is to evaluate the effectiveness of implicit bias training after it is adapted into the existing medical curriculum and training. I argue that the translational gaps exist among all these three stages, given how the implicit bias training is currently developed and being implemented. The first translational gap exists between T1 and T2. This gap reflects inconsistencies between findings from basic social psychology research of implicit bias and the content of the current implicit bias training. Again, the typical implicit bias training is didactic and brief, but this is inconsistent with what we know from the basic research on implicit bias, which suggests that implicit bias is just like an old habit. To effectively break any habit, people have to be provided with concrete strategies and be given opportunities to practice them repeatedly over time. Going back to the strip test, even with a simple task such as naming colors instead of reading words, requires repeated practice to perform well. Evidence-based habit-breaking strategies for reducing implicit prejudice include stereotype replacement, counter-stereotypical imaging, individuation, perspective taking, and contact. Social psychology research also provides strong evidence that awareness is necessary, but not sufficient in reducing implicit bias. People also have to be motivated to reduce their bias and also have enough cognitive resources to practice the habit-breaking strategies. The next two translational gaps exist between T2 and T3. One gap reflects an inconsistency between the actual and the intended goals of implicit bias training. Given how the effectiveness of the current implicit bias training is assessed, the actual goal is to either increase self-awareness or reduce IAT scores, or both. But I believe that the intended goal of implicit bias training is to improve the quality of care for patients from marginalized social groups. The other gap reflects an inconsistency between the goal of the current implicit bias training and the overarching goal of the US health system that seeks to maximize revenue. To maximize revenues, providers are often scheduled to see many patients in a limited amount of time, which makes it difficult for any providers to engage in evidence-based habit-breaking strategies, such as individuation and perspective taking. Additionally, many providers operating under the constant pressure are chronically stressed, and the stress is known to reduce people's ability to exert self-regulation, which is at the core of overriding habitual responses. These considerations suggest the situational irony that implicit bias training as currently designed might not be effective or even a realistic approach to rectifying the negative effects of implicit bias. This issue leads to the final translational gap between T3 and back to T1. I also want to highlight issues with the current approach to addressing provider bias in general. First, its primary focus on implicit prejudice is not sufficient in eliminating racial healthcare disparities because implicit prejudice is associated with just one aspect of healthcare. We also need to address providers' explicit stereotyping, which is associated with clinical recommendations. Second, we cannot lose sight of the effects of systemic racism. Individual bias doesn't exist in vacuum. Individual bias is closely tied to systemic racism at institutional and community levels. For example, the inclusion of race in medical algorithms is one form of systemic racism, and it reinforces the endorsement of a stereotype that Black people are biologically different from white people, which is a form of individual bias. So eliminating racial healthcare disparities that are attributable to providers' bias requires a multi-angle and multi-level approach. Thank you.
I can't hear you. You might be muted on your phone.
Thank you. Can you hear me now?
Yes.
Okay, great. I'm probably frozen again, but that's okay. So I just wanted to thank Dr. Hagiwara for her excellent talk and to encourage the audience to place any questions they have in the chat. But we're going to move right along so we have a good time for our panel discussion today. Our second speaker is Dr. Peter Mende-Siedlecki. He's an assistant professor at the University of Delaware, where he uses techniques from social psychology, cognitive neuroscience, and perceptual psychophysics to study intergroup social perception. In particular, his research focuses on racial bias in the visual perception of pain expression, the consequences this bias may have for bias in care, and the factors shaping this bias from both the bottom up and the top down. Previously, Dr. Mende-Siedlecki received his PhD at Princeton University, and he completed his postdoctoral training at NYU. Dr. Mende-Siedlecki will now share his expertise with us in his talk titled Examining Racial Disparities in Pain Care from Perceptual Biases to Dyadic Processes.
Okay, sorry, my
Yeah,
unmute
there you
button
go.
disappeared on me there for a second.
No worries.
Okay, well, thank you so much for that introduction, Amanda. And thank you for all having me here today. So I'm going to be sharing some work with you on perceptual contributions to racial pain disparities. I'm going to start by giving you an overview of some of the work that my lab has done, and then I'll give you an in-depth look at some new data demonstrating the speed, spontaneity, and robustness of this racial bias and pain perception. Finally, I'll close by zooming out and arguing for an approach to pain disparities that centers dyadic communication processes. There are undeniable health disparities in the United States, and in particular, well-documented and long-standing gaps in the domain of pain care. So relative to white patients, Black patients are less likely to receive pain medications, less likely to receive opioids for severe pain, and when they do, they receive lower doses. Now, these biases are evident for seemingly every type of pain and every point in the treatment chronology from the emergency room to palliative care, and they're conserved when controlling for socioeconomic status and insurance status. Now, in the context of cancer, pain can be a really critical sign leading to initial diagnosis. It can be an indicator of disease progression. It can be a prominent side effect of treatment. So pain is obviously very critical in the cancer context, and perhaps unsurprisingly, racial disparities in cancer pain have been very well documented as well. Now, given the breadth and the depth of these disparities in care, I think it's crucial to attack this problem from multiple angles. For example, some of the work that Now touched on in social psychology has explored how stereotypes related to things like lower status and substance abuse or false beliefs about biological differences between Black and white people give rise to differences in pain attribution. Other work in social and affective neuroscience has studied group-based biases and the neural signatures of empathy for pain. Still other work, again, along the lines of what you heard from Now, other work has highlighted implicit racial bias as a key factor behind these disparities. And finally, I just want to reflect on the fact that these gaps in care are fueled not simply by individual factors, but also overarching structural factors that influence quality of care and access to care, and that furthermore, historical legacies of racism are inherently intertwined with and supportive of both individual and structural level bias. So in my work, we tackled this problem from a different angle at the low level of visual perception. So we know that painful facial expressions have certain characteristic hallmarks like brow lowering and eyelid tightening and nose wrinkling. And further, we know that painful expressions contain unique information that's often distinct from other pain behaviors. They're comparatively spontaneous, they're potentially less subject to purposeful distortion versus self-report. And as such, despite a focus on self-report as a gold standard in pain assessment, facial expressions are at least given some diagnostic weight, especially in the case of non-communicative patients. So with all that in mind, we asked, do perceivers, especially white perceivers, show different thresholds for the visual perception of pain on Black versus white faces, to the point that they actually need to see more pain on a Black face to recognize that pain? So when we began conducting this work, we developed a new stimulus set in which models were posing various facial expressions of pain at various intensities in a standardized procedure. And then we used these neutral and painful expressions to create morph continua ranging from completely neutral to completely painful images, which we've deployed across numerous studies at this point. So in these studies, we show participants these faces one at a time using approaches adapted from perceptual psychophysics. We isolate our participants' individualized thresholds for seeing pain on Black and white targets. Now, I should note that in the majority of these studies, pain was contextualized relatively generally. We didn't explicitly talk about cancer pain in the majority of these studies. That being said, I do think given the sort of ubiquity of pain, the consistency of pain expression across pain experience, and the low-level perceptual nature of the bias that I'm going to be talking about, I do believe that this bias would generalize to the cancer context. Now, at this point, we've run dozens and dozens of similar studies, which we've collapsed across in a meta-analysis that's currently under review. And this meta-analysis confirms that perceivers repeatedly show more stringent thresholds for seeing pain on Black versus white faces. While many of these studies were conducted within representative samples of lay people, I should note that in our work on nursing students, we do demonstrate that these biases are robustly observed in health professionals in training. In other work, we've shown that white perceivers see pain as readily on Asian faces as they do on white faces, while still showing biased perception towards Black pain. Moreover, this tendency to see pain less readily on Black faces generalizes to Black, Asian, and Hispanic perceivers as well, suggesting that these gaps in perception are not simply a manifestation of in-group preference. We've also examined the extent to which racial prototypicality cues moderate this bias, as well as the extent to which this bias is related to similar tendencies to misperceive other emotions on Black faces, things like anger, happiness, and fear. And in that work, we see that racial bias in pain perception is considerably larger than these other gaps in emotion recognition, suggesting that this bias is particularly prominent within the context of pain and particularly specific to Black targets. Finally, we've shown across all these studies that racial bias in pain perception facilitates racial bias in subsequent hypothetical treatment recommendations. So I'm aggregating across 40 studies worth of data here, which show that participants prescribe about 1/3 of a gram less of a non-narcotic analgesic cream to Black targets as a consequence of having more stringent thresholds for visually perceiving their pain over and above the influence of explicit racial bias and stereotypes about things like social status and strength. So in sum, this initial foundation of work demonstrates that racial bias in pain perception is highly robust, broadly generalizable, and potentially facilitative of gaps in at least hypothetical treatment recommendations. But where do we go from here? Well, we've been busy examining things like target level and perceiver level factors that influence this bias, but over the next few minutes, I want to tell you about some recent attempts to confirm and characterize the perceptual nature of this bias. So in particular, I want to convince you that this bias operates rapidly and automatically, that it's exacerbated by ambiguity, and that it persists even when other diagnostic evidence is available to the perceiver. I should note that this work is very new, but that all experiments that I'm going to show you were publicly pre-registered, and that the manuscript collecting this work, which is currently under peer review, is posted publicly on SciArchive. So first, we looked into the speed of this bias. To study how rapidly this bias occurs, we examined the extent to which it's conserved under very fast presentation conditions. So if a given facial characteristic can be recognized, even when faces are shown very briefly, this suggests that processing pertaining to this characteristic is relatively automatic. And by that logic, if bias in recognition is also present under very brief presentation conditions, that suggests that the bias is similarly automatic and not dependent on explicit attention or explicit inspection of the visual stimuli. So in this study, we presented black and white versions of the same set of faces at 4 different intensities of pain from neutral, or sorry, 5 different intensities of pain from neutral to 100% painful expressions. And we also presented these at 6 different presentation durations from 33 milliseconds all the way up to an unconstrained presentation duration. I should note 33 milliseconds is really fast. It's just above essentially subliminal presentation. I'll also note that here and in many of our other tasks, we use computer-generated faces to hold expressions constant across our black and white targets. So a participant sees a face like this one, followed by a face scrambled backwards visual mask, and then they make a binary rating of whether or not the preceding face was in pain. So if bias were to be observed for longer and unconstrained presentations only, but not rapid presentations, this might call the automaticity of this perceptual bias into some question. However, overall, we observed that racial bias in pain perception was indeed obtained after presentations as brief as 33 milliseconds long, as you can see in the dark bars here, and across the graph too. Beyond that, though, what I want to draw your attention to here is the fact that the effective target race is interacting with expression intensity, such that racial bias in pain perception is largest for our most ambiguous stimuli, the 50% morphs at the middle of the continuum, the ones where it's not clearly not in pain and it's not clearly extreme pain. It's somewhere in the middle. There's a great deal of uncertainty concerning this particular image. As expressions became more clear, right? So as pain dropped off in intensity or increased intensity, this bias decreased in magnitude. So we've at this point replicated this race by intensity interaction across 3 other samples, including real, in other words, non-computer generated faces. And these data suggest that not only does this bias unfold with relative automaticity, but further, and echoing some of what Now said regarding the role of uncertainty or ambiguity in these decision processes, that it's magnified when stimuli were most ambiguous in nature. In other words, when the pain signal presented on the faces was at its most uncertain, that was when bias could creep in most readily. Another way to test the automaticity of this bias would be to hinder perceivers' ability to engage more deliberate processing mechanisms. So specifically, we can put participants under conditions of cognitive load to see if this reduces their perceptual bias. Now, typical cognitive load manipulations tax our working memory and deplete our attentional resources, and in turn, disrupt effortful processing. So what we can do is use a classic cognitive load manipulation in which participants have to rehearse either a simple or a complicated multi-digit number, which we described as our target's patient ID numbers, while completing our standard pain rating tasks, making those ratings of these face morphs one by one. In this study, since we're using computer-generated faces, we can counterbalance the assignment of expressions to faces and faces to condition, so that we're confident that those dimensions aren't, kind of adding confounds into our effects. Now, if racial bias in pain perception were to be reduced in the high load condition, this might suggest that this bias is not automatic, perhaps that it requires the effortful, explicit application of beliefs about biological differences between black and white individuals, racial beliefs about pain tolerance or pain sensitivity, for example. However, if this bias doesn't vary between low and high load, this would be evidence of the bias's spontaneity. And indeed, we observed no interaction between target race and cognitive load. Participants in the study displayed significantly greater thresholds for seeing pain on black versus white faces in both the low and the high load conditions, suggesting that load did not, in fact, disrupt this perceptual bias. We also replicated this finding in a different sample using photographic rather than computer-generated stimuli. Here we once again observed no interaction between cognitive load and target race. Participants are displaying evidence of racial bias in pain perception in both the low and the high load conditions, suggesting that racial bias in pain perception is indeed spontaneous and not dependent on effortful, controlled processing. That being said, even if this bias, this perceptual bias, is spontaneous, it's possible that it could be easily corrected for given the proper diagnostic information. So for example, self-reported pain severity is often considered the gold standard clinical measure of a patient's pain experience, which begs the question, does this perceptual bias maintain in light of self-reported pain experience? So to test this possibility that other diagnostic information might eliminate racial bias in pain perception, we described a standard numeric pain rating scale to participants, and then manipulated target race and pain self-report orthogonally from one another. Specifically, we ascribed either ambiguous self-report values or high self-report values to targets and held expression intensity constant across the self-report conditions. We again counterbalance assignment of targets to condition, heads to race, and expressions to head across participants. So overall here in this study, participants once again saw pain less readily on Black faces, evidence of the pervasiveness and robustness of this perceptual bias, but the effective target race did not show significant variation based on self-report. That said, if you look within each condition, it does look like the effective race is not statistically significant within the high pain condition. It's possible here that this was a function of our decision to include 10 out of 10 values in the high condition, which may have led to something of a ceiling effect. So to address this, we conducted a replication, this time using real faces and only using 4 and 7 for the ambiguous and high self-report values, respectively. Here we continue to observe a main effective target race that generalized across each self-report condition, and the interaction between target race and self-report was once again not statistically significant. Thus, collapsing across these two studies, we can conclude that racial bias in pain perception is conserved even when self-reported pain experience is available to perceivers. So at this point, across 5 studies, I've offered you evidence that racial bias in pain perception emerges rapidly and most prominently when pain expressions are ambiguous in nature. Moreover, I've offered you evidence that this bias is automatic, not dependent on effortful processing, and conserved when other diagnostic information regarding pain experience is available. And in the context of the overview I gave you, I think that this does make a relatively strong case, as I said before, for a perceptual contribution to racial biases in pain outcomes. But at this point, I want to take a step back and acknowledge that this is only a small piece of the puzzle. What I haven't shown you, for example, is how these various factors might interact with each other, how perceptual bias might relate to implicit racial bias, how stereotypes related to pain might interact with biases in empathy or perception. I haven't talked about how these bias promoting factors might interact with bias combating factors like intergroup contact or cultural competence. More critically, I haven't talked about how these perceiver or provider level factors might interact with patient level factors like experiences of discrimination, for example. Indeed, everything I've told you so far has considered bias and disparity from an individual focused perspective. But the context in which these biases really operate is a dyadic relationship between patient and provider. And if we're thinking about a dyadic relationship, we need to be thinking about communication processes and how all these individual factors come to influence communication. Now, this shouldn't come as a surprise. Obviously, interpersonal processes are inherent to pain experience and pain evaluation. And as Now was arguing before, I think very convincingly, successful pain care requires constructive communication and negotiation processes between patients and providers. Now, since Black patients tend to interact with non-Black providers, and since racially discordant medical interactions tend to be less productive and less positive in tone, is it possible that Black patients are experiencing disruptions specifically in these dyadic processes at the heart of this relationship? So these are exactly the questions that Now and I started asking each other a few years back when we met on that CASPER panel that Amanda mentioned at the outset that was hosted by NCI. And we were, really fascinated with figuring out how to put this all together in one model. And we've had lots of, time to work in the intervening years to think about this and talk about this and build up this model. So, a look at the literature suggests that while there is this extensive catalog of patient and provider level factors that have been identified, they're typically studied in isolation. And from this perspective, these factors have separate, dissociable influences on pain outcomes that typically don't interact with each other or work through dyadic processes. even when communication is considered and is foregrounded, patient and provider communication behaviors are still considered separately from each other. For example, you might have a case where you'd say, okay, well, provider implicit prejudice is triggering negative provider communication behaviors, and that's having negative consequences for care or negative consequences for patient-centered outcomes. That may be true, but that perspective doesn't consider how the provider's communication behaviors may influence the patient communication behaviors regarding pain in turn, which may elicit further responses and perceptions and judgments and evaluations from the provider. So said a bit more simply, the current approach is failing to consider these dyadic processes between patients and providers that feed off and fuel each other dynamically. So we think that this fragmented approach is going to ultimately hamper our understanding of racial pain care disparities because these decisions are not made unilaterally in a vacuum. So working with our surgical collaborators, Now and I have recently proposed a conceptual model that seeks to shift current research paradigms in pain care disparities. In this model, patient and provider factors can still influence pain outcomes, but they do so through dyadic communication processes, thus making this a key mechanism underlying and a key intervention target for reducing racial pain care disparities. Now, implementing this model is going to require significant changes to our approach. We need to focus our research designs on studying the entire chronology of the pain negotiation in naturalistic clinical settings. This is going to enable us to identify new intervention points that are more realistic, more ecologically valid, and in turn, more feasibly intervened upon. Second, to highlight dyadic processes between patients and providers as our core unit of analysis, we need to employ a multi-method approach that integrates across a variety of analytic tools. In particular, I think we need to be recruiting both skilled quantitative collaborators and skilled qualitative collaborators to capture not just the nature of these dyadic processes, the behavioral coordination across these nonverbal, paraverbal, and verbal levels, but also the underlying why and how behind this coordination. And finally, these 2 points highlight the necessity of having interdisciplinary teams. So to study these disparities in real-world settings, physicians and clinicians and surgeons must be centrally involved in this research. In turn, we need social scientists to help progress this work beyond merely a catalog of disparity features and towards an understanding of their underlying mechanisms. As I just said, to capture the dynamic and dyadic processes fueling these disparities, we need research teams with both quantitative and qualitative statistical expertise. And finally, I think this work will be fruitless if it doesn't center Black patient voices, members of the community who are most affected by this disparity. So research teams are encouraged to include community partners or work with a community research advisory board to amplify Black patient voices and center them in this work. So with that, I know I'm at time, so I just want to thank my amazing lab, my fantastic grad students, Alexis and Azadeh, my former and current research assistants and lab managers, Jingran, Azar, and Patrick, my funders, my additional collaborators, especially now. It's so great to be on a panel with you here today now, and you for your kind and patient attention.
Can you hear me okay?
Yes, we can hear you, Amanda.
Thank you. Thank you, Dr. Mende-Siedlecki, for your wonderful talk. We're going to keep moving right along to our third speaker, Dr. Lauren Hamill. She is an associate professor and scientific member of the Population Studies and Disparities Research Program at the Karmanos Cancer Institute and the Wayne State University School of Medicine in Detroit, Michigan. Dr. Hamill is an expert in patient-physician communication, cancer treatment disparities, and in building and testing interventions to improve patient-physician communication. She was PI of 2 recently completed NIH-funded studies assessing nonverbal synchrony and nonverbal communication that occurs between Black patients with cancer and their oncologists during clinical interactions. She is investigating aspects of nonverbal communication as potential markers of racial attitudes and predictors of interaction outcomes. Currently, Dr. Hamill is PI of an American Cancer Society Research Scholar Health Equity Grant to test the effectiveness of patient-focused intervention, the DISCO app on patient-provider treatment cost discussions, and other patient financial toxicity-related outcomes. She has published her work in 30-plus articles in peer-reviewed scientific journals, including Cancer, the Journal of Clinical Oncology, and JCO Oncology Practice. Dr. Hamill will now share her expertise with us in her talk titled Investigating Nonverbal Communication and Synchronized Behavior in Cancer Treatment Discussions with Black and White Patients.
Thanks, everyone, and thank you for that introduction, Amanda. I realized I must have edited my title. I like the first one better, so I'm going to go back to what you said, not what's on the screen. So as Amanda said, I am an associate professor at the Karmanos Cancer Institute in Wayne State University in Detroit, Michigan. And today I'm going to be going over some work that I've been working on with my team for the last couple of years. And really what it does is kind of, I think one of my broader research goals is furthering the methods and understanding that we have of the dynamic nature of human communication, and specifically between patients and physicians. So you'll see here that I'm investigating certain aspects of nonverbal communication, how that communication is influenced by race-based attitudes, and then in turn, how those attitudes and communication influence outcomes. So really what I'm trying to do is enhance the sophistication of the methods that we use to investigate these kinds of questions. So a quick overview for what I'm going to go over today. First, I'll discuss how patient attitudes and perceptions and communication are contributing to health disparities. I'll quickly go over the nature of communication that occurs between Black patients and their physicians. And I'm also going to discuss the importance of attitudes and why we think that will influence nonverbal communication in clinical interactions. And then last, detail the latest research I've conducted that's examining how attitudes are influencing jointly determined communication behaviors in clinical interactions. So I know I'm preaching to the choir here, but for completeness sake, I just want to talk about kind of what prompts this research. And it's the persistent disparities that we observe in cancer treatment and cancer outcomes. I think the previous speakers talked a little bit about it. Black cancer patients are less likely to receive treatment for several types of cancer. And if they do receive treatment, it's more likely to be delayed or non-standard. We find that this persists even when we control for things like stage of diagnosis, disease aggressiveness, comorbidities, physician access, insurance, and referrals. Now, this here is the cover from the American Association for Cancer Researchers report on cancer disparities in the US that came out last year. And it sought to answer why cancer disparities exist in the United States. And it concluded that among the most important factors are social determinants of health. And that's defined by the NCI as conditions in which people are born, grow, live, work, and age, including our health system. They also estimated that 34% of cancer deaths among US adults ages 25 to 74 could be prevented if socioeconomic disparities were eliminated. Now, there are many contributing factors to treatment disparities, of course. The two that I focus on are patient-provider communication and patient-provider race-based attitudes. And I'm going to talk about that a little bit more specifically here. So the attitudes that my work focuses on, it's both on the part of the physician and also the patient. And most often those patients are Black or African American. So physicians, I focus on implicit or non-conscious bias. And of course, Dr. Hagiwara gave a great description of what that is as a phenomenon. For patients, I look at suspicion of the medical treatment they may receive, trust in physicians and medical institutions, previous experience with discrimination in healthcare, but also in other contexts like employment, criminal justice, and schools, and then also distress related to cancer treatment. So previous research has found that implicitly biased physicians are perceived more negatively by Black patients and are more verbally dominant with Black patients. Again, Dr. Hagiwara gave a far more descriptive understand or a more in-depth description on this. We also see that highly suspicious Black patients are perceived to be less educated and less intelligent by their physicians. And we also see that Black patients lower in trust of medical institutions and who have previously experienced discrimination tend to talk more during their interactions with physicians. So what this research is, kind of the upshot of this research and similar research is that racial attitudes exist, both on the part of physicians and patients. They're persistent, and they're influencing communication and in turn outcomes. And I think importantly, we see differences in how they're perceiving one another, even when the individuals aren't aware of the attitudes they hold themselves. So I have a background in nonverbal communication, and studies of non-medical interracial interactions find that attitudes or other perceptions are more likely to be expressed through less deliberate nonverbal communication, like facial expressions or posture, than through more deliberate verbal communication, like the words that we speak. So as an example, we might see discrepancies in the words that are spoken and how they're spoken. So perhaps a physician is using comforting or supportive words, but doing so without finding or maintaining eye contact, or speaking very quickly as if in a hurry to get done. So in communication science, we often say you cannot not communicate. So in this case, maybe that when the words are, even when the words are appropriate or correct, the accompanying nonverbals may say otherwise. So my team and I have recently published a paper in Cancer. This work was funded by an R03 I had from the NCI. And what this paper did was apply network analyses to investigate discrete nonverbal behaviors between physicians and their Black patients. So you'll see a screen grab of an example of what one of those network analyses look like. Now, this certainly shed more light into the dynamic interplay of nonverbal behaviors. As an example, for previous research, a lot of medical communication research focuses on counting and sums. So we'll count number of smiles, we'll count questions asked, we'll count changes in posture, which gives you a sum at the end. What we really wanted to do was, again, shed more light into the dynamics of those interactions and understanding that over the course of a treatment discussion, lots of things can change, and it's not just a static interaction. So this study, certainly moved that forward. We were able to enhance the methodological sophistication of tracking and analyzing human communication behaviors. But there were two things that it lacked. One was a white comparison group, and two were attitudes as predictors of these behaviors. So with this in mind, my team and I have been investigating a mechanism that's gaining attention in other areas of study called nonverbal synchrony. Now, nonverbal synchrony is the non-conscious coordination of physical movement that occurs between individuals during an interaction. And the reason why I always bring Fred and Ginger with me when I talk about this is because synchrony was first measured with ballroom dancers as dyads who are completely in sync with one another. But even more than for dancers, nonverbal synchrony is an automatic coordination that occurs between two people, and there's evidence that suggests it's an important marker for relationship quality. So here's a quick screen grab of the protocol of the study we published a few years ago, and it was a secondary analysis using data from two previous R01s. So previous research has found that nonverbal synchrony acts as both a consequence and a predictor. So we see people synchronize more with others with whom they have positive relationships, people they want to develop positive relationships with, and with people they trust. We also see that nonverbal synchrony reflects positive affect, liking, similarity, closeness, and rapport. And perhaps more germane to our context, it also positively influences therapeutic processes, cooperation, adherence, and memory. So my general argument for this particular study, which I also wanted to mention was funded by an R21 I had from the National Institute of Minority Health and Health Disparities, was that nonverbal synchrony is subtle, unintentional, automatic, and affect-laden. It's likely that the manifestation of the race-based attitudes I'm interested in is also subtle, automatic, unintentional, and affect-laden, and could potentially be an important indicator for relationship quality and outcomes in clinical communication, especially as we examine the influence of racial attitudes. So my study included three hypotheses. The first was a prediction that the level of nonverbal synchrony will be greater in racially concordant or interactions with white patients compared to racially discordant or interactions with Black patients. We predicted that the level of nonverbal synchrony would be associated with indicators of communication quality, including physicians' patient-centered communication, and patient and physician's individual affect and their relational rapport. And we thought this would be the case in both racially concordant and racially discordant interactions. And then last, for interactions with Black patients, so racially discordant interactions, that we would see racial attitudes and other perceptions be associated with those nonverbal synchrony metrics. So as I mentioned, we conducted a secondary analysis from 2 previous R01s. We had 163 white patients and 68 Black patients with cancer and their non-Black medical oncologists. And these data were all collected from 3 different National Cancer Institute designated comprehensive cancer centers. We had video recordings of all of the interactions and patient and physician demographic data. We also had observer ratings. So as I mentioned, everything was video recorded. So we had trained observers assess each interaction for physicians' patient-centered communication, and also patient and physician's individual affect and relational rapport. For the Black patients, we had assessments of their and their physicians' race-based attitudes and perceptions. So physicians, we had physician participants completed the implicit association test for racial bias. We also had patients' assessments of group-based suspicion of medical care, trust in physicians and medical institutions, previous discrimination, and distress. To assess that synchronized movement, we use motion energy analysis software. Now, MEA assesses nonverbal synchrony by tracking behavior at the pixel level in video recorded interactions. So here's a screenshot of what that software looks like. So you upload a video, you indicate where on the video you want your behavior tracked, and run that through the software, which gives you gives you quantitative data to make those assessments. And from that software, we were able to look at a few different outcomes related to nonverbal synchrony. The first was global synchrony, which is all correlated motion, both positive and negative. If you hear of others talk about synchrony or synchronized behavior, this is usually what they're referring to. We also looked at who was leading and who was following on average across the interaction. So was the physician adapting his or her behavior to the patient or vice versa? And then we looked at any differences in synchrony when the physician was leading compared to when the patient was leading. As I mentioned, we had 68 Black patients and 163 white patients. The average age was not quite 60 years of age. Black patients, we had mostly female patients, and they saw both male and female physicians. White patients, we had 46% female, 54% male, and they saw only male patients. Male physicians. So our analyses included multi-level models. So we had synchrony measures nested within patients, which were nested within oncologists, to determine first if nonverbal synchrony differed in interactions with white patients compared to interactions with Black patients, if synchrony was associated with observed physicians' patient-centered communication, affect, and rapport, and if patient and oncologist race-related attitudes and perceptions influence synchrony measures and interactions with Black patients. So as a reminder, here was our first prediction that we would see greater levels of nonverbal synchrony in racially concordant than in racially discordant oncology interactions. And in fact, contrary to what we hypothesized, we found greater levels of all synchrony metrics in interactions with Black patients compared to interactions with white patients, which to me says that nonverbal synchrony may not simply be good or bad, but may be indicative of something that's going on in the interaction or the relationship with 2 people. Now, to add to this argument, we also examined how much synchronized behavior occurred based on who was leading and who was following. And you'll see here that the synchrony that was observed in interactions with white patients was the same, regardless of who was leading, whether the physician was following the patient or the patient was following the physician. But in interactions with Black patients, we see that there was greater synchrony with Black patients when the physician was following the patient. So it seems that interactions with Black patients have something that's going on that simply isn't present in interactions with white patients. So regarding our second hypothesis, which predicted that nonverbal synchrony would be associated with indicators of communication quality, we saw that in interactions with interactions with Black patients, the longer the patient took to respond to the physician's behavior, the less patient-centered the physician's communication was observed to be. We did not find that in interactions with white patients. So kind of said differently, when Black patients were observed, and again, these were observer ratings, so it was kind of a trained third party looking at these interactions, that when Black perhaps struggling to follow the physician, either behaviorally or maybe logically, the observed patient-centered communication of the physician decreased. Again, not something that we found in interactions with white patients. Now, for our analysis of nonverbal synchrony and individual affect and relational rapport, I have all of our findings displayed here, and I'm not anticipating anyone's going to examine each individual finding. And in fact, I struggled with how to display this so that I could kind of get the overall pattern conveyed accurately. So to orient you really quickly, you'll see that all of the associations in bold were positive. All of the associations underlined were negative. The green columns show positive affect and rapport, and the red columns show negative affect and rapport. So I thought I would just draw your attention to the striking differences and the number of significant associations found based on the racial composition of the dyad. So you'll see here the associations found in interactions with Black patients. Far fewer, I should say, were found in interactions with white patients. So you see here again, you see a lot of significant associations, all in the predicted directions, compared to interactions with white patients that had far fewer. So I think, again, suggesting that this particular phenomenon, the synchronized behavior, may be more important or more pronounced or more critical in those interactions with Black patients compared to white patients. Now, for our final hypothesis, we predicted that we would see associations between racial attitudes and perceptions, those associations would be evident with nonverbal synchrony. And again, the attitudes and perceptions you were looking at included physician implicit racial bias, patients' group-based suspicion of medical care, patients' trust in the physicians, patients' previous discrimination, and patients' distress. And I should say, we are getting these findings hot off the analytical press. My collaborator and I have just been working on these. So here are our preliminary findings. You'll see the predictors in the left column and the synchrony outcomes along the top. So we looked at global synchrony, synchrony when the physician was leading, and synchrony when the patient was leading. And you'll see we found some interesting relationships between physicians' implicit bias, overall synchrony, and also synchrony, based on regardless of who's leading, whether it's the physician or it's the patient. We also see some interesting relationships for patient attitudes and perceptions, including trust in physicians and also patient distress. So I think what this means for cancer interactions is still something I think we need to interrogate and spend more time thinking and kind of figuring out. I think for my methodological goals, this is one of the first studies to examine the reciprocal nature of naturally occurring communication using a jointly determined measure. So we didn't count individual behaviors and kind of sum them together or correlate them together. We found a behavior that both are contributing to. Contrary to our hypothesis, we saw that nonverbal synchrony was greater in interactions with Black patients than in interactions with white patients, and that Black patients appear to be driving more of the synchrony in their interactions compared to white patients. When Black patients were struggling to follow the physician, the observed patient-centered communication, in fact, decreased, but we did not see that finding or that association for interactions with white patients. So I think taken together, these findings are suggesting that there may be more to overcome in interactions with Black patients compared to white patients, and that perhaps physicians are adapting their behavior to their Black patients in an effort to bridge perceived differences. So of course, I'm looking at this, in cancer treatment discussions. When I was asked to contribute to the panel, I thought it was a great opportunity to start thinking about how nonverbal synchrony may be working in more specific instances or more specific contexts, like pain. And I think our previous speakers, did a great job of, differentiating or describing the disparate experience of pain or pain management or pain communication that patients who are Black and white may face. I think, one thing that, we go to is in enhance or increase patient-centered communication skills as a way to overcome those disparities. I'm sure interactions about pain would be included in that. One thing I'm really anxious to do with this work is to start examining the extent to which patients and physicians synchronize their behavior, how that influences outcomes. I'd love to look at things like treatment decisions, but also the experience and management of pain, which is certainly a part of treating and experiencing or being diagnosed with cancer. I think, looking at nonverbal synchrony and other nonverbal behaviors as indicators of communication quality. So implementing interventions, maybe using something like this to assess its effectiveness. And, I also too want to point out that one of my close colleagues, Dr. Synchrony, has written pretty extensively on the experience of pain in the cancer context. And she and I have, discussed how can we take what, the data that she's already investigated and analyzed in previous papers and, kind of tie it in with what we're doing here. So assessing nonverbal synchrony in specific contexts. I think, we've got a huge archive of video recordings of patients and physicians talking about any number of issues related to cancer, including pain. And, we're, well positioned to kind of pull those instances out of our archives and interrogate them further using this method, but also other assessments of that communication and the outcomes of those interactions. So before I finish, I just want to say a quick thank you to my collaborators and the NCI and the NIMHD that supported this work. So thank you.
Dr. Hamill, thank you so much for your talk. Can you all hear me?
Mm-hmm.
It looks like I'm frozen. Okay. Thank you all for being patient too with my technical difficulties, but I'm very glad that at least the phone is working so y'all can hear me. So last but not least, our discussant today is Dr. Paul Hahn. He's a senior scientist in the Behavioral Research Program. Dr. Hahn's research program focuses on understanding and improving the communication and management of uncertainty in healthcare, and his work bridges the disciplines of behavioral and health services research. Dr. Hahn is the author of Uncertainty in Medicine, a Framework for Tolerance, as well as over 150 papers and book chapters in the peer-reviewed medical literature. And he's been actively involved in initiatives to promote shared decision-making and teach risk communication skills to medical students and physicians. Dr. Hahn will now share his expertise with us in his talk titled Psychological Barriers to Equitable Evaluation and Management of Cancer Pain, the Role of Uncertainty.
Thank you all. And I hope you can hear me. If you can indicate, if you can't, just let me know. I want to thank you all for the opportunity to participate in this webinar, and also to thank the speakers for a terrific and very provocative set of talks, and really look forward to further discussion of what was presented today. I wanted to provide just a few general comments as someone who's interested not only in the problem of uncertainty, but someone who used to be on the front lines of treating pain in cancer patients. I'm not currently doing this, but I do want to draw on some of my own experiences to offer a personal perspective on what I see as a fundamental problem underlying inequities in cancer pain management, and that's the problem of uncertainty. And my goal isn't really to provide any definitive answers to this problem, but to raise some questions that might be useful in further research and understanding what we can do to reduce these inequities in pain management. And let's see if I think I'm able to, oh, here we go. All right, sorry, I think I'm having a little bit of trouble controlling slides, but so psychological barriers to equitable pain management. As we discuss these, it's a very complex problem because it originates from disparities in either pain evaluation, pain management, or treatment, or both. And I think our speakers today really highlighted some of these issues, primarily involved with pain evaluation, but there's a whole other set of considerations that need to be thought about in this space, including how we translate the assessment into treatment decision-making. So it's a really complex set of issues that I think we need to think about. Regarding biases in clinicians' evaluation and management of pain, there's several potential sources, and our speakers really did a really fantastic job, I think, talking about several of these very important sources. Dr. Hagiwara really talked about explicit and implicit stereotypes and prejudices that lead to discrimination in how people manage pain and what types of, and how they react to it, what types of interventions they might choose. Dr. Mende-Siedlecki talked about rapid and automatic biases in pain perception and the mechanisms of these biases. Again, hinting at the significance of how these biases might affect actual pain management decisions in patients. And finally, Dr. Hamill talked about nonverbal miscommunication or a lack of synchrony due to race-related perceptions and attitudes and potential implications of this sort of miscommunication between providers and patients. And both Dr. Hagiwara and Dr. Mende-Siedlecki also talked about the importance of provider-patient communication and the dyadic relationship in general, and how these biases become manifest through communication, ultimately to influence the way that pain is treated. I want to put out a perspective that all three speakers talked about and drill down on this a little bit more, that really, if we think about underlying mechanisms, fundamentally, I believe the root cause of these biases and inequitable pain management is actually medical uncertainty. It's uncertainty about not only the extent of pain that people experience, but what to do with that pain. This type of uncertainty is really the precondition for inequities. It opens the door to the influence of various psychological biases. And the problem is that there's multiple uncertainties. There's not just simply one uncertainty that we're dealing with. There are multiple different uncertainties that I'm going to talk about in a minute. And moreover, these uncertainties are unavoidable, and they're also irreducible. I want to take us back to clinical reality for a second and just ground us in what we're doing. And what we're really talking about is a lived experience of real patients who are suffering. And what do we do with this when we're confronted as providers, as health professionals, or as loved ones when there's a person who's suffering in pain? And there's a deep, I think the deepest source of uncertainty is the question of, can we actually ever really know another person's pain? And that's what pain management is all about, that we're trying to know that. But there's a fundamental, I think, kind of inscrutable nature of the problem we're dealing with. And it's the fact that this is really a subjective experience of people. And can we actually ever really know, and how much can we know another person's pain? We like to think, I think, on the side of assessment and evaluation, that this is really something that we can quantify. And here, clinicians are very familiar with these numeric rating scales and the FACES rating system. And there's a lot of sophisticated measurement systems that have been developed to help clinicians as well as researchers assess levels of pain. But then the question is, are any of these evaluations of pain objectively correct? How do we translate the subjective experience of a suffering person into some kind of a form that we can actually agree on and then make decisions about pain management? We also like to think that our management of pain, even if assessment were, we could agree on some amount of assessment as far as what the level of pain is, but then what do you do with that? And we like to think that we have a whole armamentarium of tools. This is an opioid analgesic equivalence chart that clinicians will be familiar with. And there are many different opioids. There's also non-opioid therapies. There's more interventional pain therapies. There's a whole slew of things that can be done for a given level of pain. And we like to think that we can boil this pain management problem into kind of an objective kind of matter, or an objective kind of task that clinicians can perform. But then still there's a lingering uncertainty of, are any of these treatments objectively correct? And what what is the correct, right treatment for any individual person who's suffering with pain? I think that clinicians, what all clinicians struggle with is that what we're really dealing with pain and pain management is fundamental ignorance about a lot of things. Number one, diagnostically, there are several questions that go through every clinician's mind in how we manage pain. How much objective pain, so to speak, is the patient subjectively experiencing? How reliable or valid is any one person's self-reported pain? And we use things like the 0 out of 10 scale, etc. We make decisions, very important decisions about what that level of pain is based on patient's report, but is a 6 out of 10 the same for two different individuals, or even for the same individual who's suffering a particular illness or problem? What's the cause of the pain? And is it sheerly physical? Can we point to a lesion that's causing this pain? What's the emotional contribution, or even the existential contribution to pain? And how do we react? And are there fundamental differences in these sort of etiologies of pain? Prognostically, what's the expected course of pain in any individual, both with or without intervention? And then finally, therapeutically, what are the expected benefits and harms of any given treatment option that we might take for any given level of pain? How much pain relief can we actually expect? And of course, all clinicians and patients are concerned about tolerance and addiction as well, particularly with opioid therapies. What's going to happen to that individual patient who's suffering in front of us? So there's myriad issues of uncertainty that we as clinicians are constantly dealing with. There's also several different sources. If we think more deeply about where do all these uncertainties come from, first of all, there's just inherent complexity, as I've tried to illustrate. There's multiple different issues of uncertainty and issues of ignorance where we simply don't know what the right answer is for any given patient. There's inherent ambiguity arising from, obviously, I've talked about the subjectivity of the pain and its unknowability for another human being. There's also individual differences between patients and within patients about their thresholds for tolerance and for reporting pain and for the response to treatment. And unfortunately, there is no dolorimeter, as my colleagues used to say. There's no objective test we can do to prove how much pain someone is really experiencing. We have a lot of ways of getting clues of that from physical signs and other means, but there's no unfortunately objective measure of pain. So there's inherent ambiguity. And then finally, I think there's fundamental paradoxes in the whole enterprise of assessing and managing pain. Fundamentally, what we're trying to do is to objectivize a subjective phenomenon. And I think that there's an uncrossable chasm there that we're always dealing with attempt back what it individualized or
Well, it sounds like you're cutting in and out on my end. Is everyone else hearing that as well?
Yes, I can no longer hear.
Well, we will work to get you reconnected. Quickly stop sharing. All right, as we work to get Paul back and connected, just as a reminder, please remember to submit your questions and your chat in the Q&A and the chat panel, and we will be moderating those on your behalf. Paul, are you back? Paul, is that you?
Can you all hear me?
Yes, we can hear you.
Very sorry about that. My computer just crashed here,
Yeah.
so I'm back on. Do I still have control of the slides?
Yep, let me just pull them back up for you. 1 second.
Sorry about that, everyone. Okay, got it, I think. Okay, so I think where I left off, I apologize. The second paradox is that the fundamental task in managing pain is to really individualize, of course, but we have to do that as clinicians based on generalizations. And that's what medicine is all about, is making generalizations from the body of scientific knowledge about how different types of people respond to different treatments. But there's a fundamental paradox and tension there, is that we rely on generalizations because we have to, even when we're trying to individualize. And I'm going to say a little bit more about that in a minute. It looks like the slide's not really moving for me. So fundamentally, the task, I think, at hand, when we talk about what is optimal pain management, I think that's a matter of uncertainty management. And it shifts the focus, I think, to how we can then better manage uncertainty about an individual's pain. We've talked about heuristics or mostly biases that influence pain management. And we've talked about, or I've tried to make the argument that uncertainty in pain management is irreducible, that there are several things that just won't go away. We have to actually accept uncertainties and manage them. It means, I think, that we have to, in some sense, we have to rely on some type of heuristics, and we will always be biased to some extent, as clinicians. The question is, do we rely on heuristics and biases that are justifiable and acceptable? And these are things that are consciously learned and teachable, things that clinicians rely on to manage all medical problems, clinical pathways, algorithms. These we consider to be warranted generalizations and warranted heuristics and biases that guide management. On the other hand, there are many unconsciously learned or medically unjustifiable and socially unacceptable types of heuristics and biases. We've talked about that today. These get to things like implicit biases and unwarranted beliefs and attitudes and generalizations. So it's not really a matter of getting rid of biases and heuristics, but choosing ones that are appropriate and acceptable. And how we do that, I think, comes down to really a problem of managing uncertainty in the appropriate way. And we have to think about, I think, as researchers as well as clinicians, try to tease apart what is it? What's the individual variation or the differential reliance on various things, differential reliance on particular heuristics or biases, and try to descriptively get a sense of what's the range, what are people actually doing? And the other speakers today have talked about particular biases, racial biases, and how we can understand those better. And then the differential effort that people make towards subjectivizing pain, that is treating it as whatever the patient says it is, versus trying to objectify it in some way. And then also differences in how people approach the individualization of care, treating every patient as unique versus trying to generalize. And these are very deep fundamental tensions. But it all comes down, I think, to trying to reduce unwarranted variation in how we manage uncertainty. The question in my mind that the speakers raised in terms of attacking these unconscious, automatic, rapid acting biases that we have on a perceptual level, as Dr. Mende-Siedlecki mentioned, is really a question of, is there some way that these unconscious rapid biases be brought under conscious control? And can these biases actually be unlearned? And are there ways that we can intervene on that level and how clinicians approach patients and interact with them? And I think what it comes down to is thinking about developing kind of a different attitude among clinicians, a mindful attitude or a metacognitive awareness where we as clinicians are more reflective about what we're doing. We have some humility and flexibility that we don't know the right answer for any given patient and what level of pain that they're experiencing. But we need to be self-critical and mindful in how we're approaching them. And then it raises a larger question in my mind of whether we can actually intentionally cultivate this type of kind of approach or mindset among clinicians. And several of the speakers mentioned this is really a multi-level problem, and it means going beyond the individual, looking at the system and relationships, and what we can do as a healthcare system to really build that type of tolerance approach. And that's all I have. So thank you for your attention, and my apologies again for the technical difficulties there.
Thank you so much, Dr. Hahn, for your remarks. I'm going to switch over to my co-moderator, Dr. Rebecca Ferrer, who will be leading the Q&A panel discussion between the speakers and the discussant today.
Hi, thanks, thanks Amanda. Can everyone hear me? Yeah. I'm gonna go with, I'm saying yes, although, okay, so I am very sorry. My WebEx crashed, but hopefully you all can still hear me. Clearly the updates to WebEx this week on the NIH end have not been incredibly user-friendly. So I have a question for all of the panelists. It came up during Peter's talk, but it seems like it's related to all of the panelists, which is what role might culture play in some of these findings? So, you know, with respect to visual pain recognition, for an example, in an applied naturalistic context, norms surrounding the expression of pain can further perhaps exacerbate pain recognition biases. So I'm just, you know, to all of the panelists, do you have any thoughts on how culture might sort of influence the processes that you are examining?
Yeah, I think that's a fantastic and fascinating question with lots of different potential inroads. You know, for someone who focuses on the perceptual side of bias here, the thing that comes most readily to mind is intergroup contact and, you know, differences in one's perceptual experience of the world, the faces that you see, the inferences that you make from those faces that you see, and how early that perceptual experience can kind of train up your visual system. I mean, we know from work on sort of the developmental aspects of perception that differences in, you know, race-based differences in face perception that we think of, you know, as sort of falling under the heading of like the cross-race effect, for example, these are getting trained up into the system as early as, you know, 9 months into development, if not earlier. So in that sense, culture, I think, plays a huge role in setting the priors for the system that can promulgate downstream bias.
And I want to add that there is a program of research in social psychology by Dr. Goff looking at dehumanization. Like there is, our culture, United States, is full of animalistic image, particularly apes associated with Black faces. And those images can have a huge impact on our bottom up, like, attitude and beliefs. So I think the culture, what kind of images, what kind of messages we are disseminating has a lot to do with individual beliefs and attitude.
Of course, I agree with the rest of the panel that culture would be an important piece of this. And I also am interested in understanding how some of the more recent cultural humility interventions that physicians have been taking on, or other providers too, not just physicians, would have any influence on the kind of communication or expression of attitudes that we would see in interactions with patients from different racial groups.
Okay, so I have another question for everyone, which is that implicit bias seems to play a role in all of your models in some way, but as has been mentioned, interventions to address implicit bias are often ineffective. It might not be the best leverage point for intervention. So, you know, I would be interested in all of your thoughts about the best way to perhaps indirectly intervene on the outcomes affected by implicit bias through other avenues.
I agree with the statement there. I don't think it's a best way to address implicit bias directly. It's, you know, the fundamental attitude and beliefs, it's really resistant to changes. So my approach has been to really identify bias associated behaviors that are more relatively modifiable and directly associated with patient outcomes, patient-centered outcomes. So, Peter and I have been looking at what kind of dyadic communication might be associated with the patient outcomes, and that we might be able to directly address the dyadic, restoring the dyadic communication as opposed to challenging individual, you know, provider's bias and also patient attitude. And this is not to discount any effort at the systemic level. So this has to be simultaneous. Like, again, the structural level is also resistant to changes. I think that policies are carefully designed to maintain the status quo. We've been talking about racism for decades. And why there's no change? Because some group benefit from those. So with that, while, you know, policy level, structural level intervention is developed, we have to still address the individual level to really have an immediate impact. So I think it's a multi-level approach to reducing bias, not bias, but disparities in care.
Yeah, and I think related to what Now just said, I kind of the mind that, I mean, implicit, how should I say, behaviors in general are resistant to change, but certainly something as inherent and implicitly built in us as this. But I often try to counsel, well, if you can't change, you know, your wired associations, do what you can to create an environment where they're less likely to be activated. So we know that there are things that enhance the effects of implicit bias. So working in an environment where maybe it's less likely for that to happen, I think would also be a fruitful avenue.
Yeah, I couldn't agree more with both Lauren and Now in this case. I mean, there's been several meta-analyses that have come out over the past several years of comparing, sort of pitting various implicit bias interventions against each other and demonstrating very, you know, relatively weak effects that don't persist for long periods of time and don't necessarily translate to behavior. And as we're all saying, that's really the key here, is not just the bias, but the behavior that stems from the bias. We've been piloting some training approaches to, you know, bring, you know, perceivers into awareness of the possibility of these biases, but also to try to explicitly direct them to at least in a perceptual context, to focus on more diagnostic features of the face, for example, to focus in on areas that are going to be more reflective of pain, et cetera. But even that, you know, we're seeing relatively small benefits in terms of changes in bias, and consequences for behavior are yet to be determined there.
What I thought was a really interesting question, you know, in this sort of COVID era where a lot of our interactions with providers are happening through telemedicine or other, you know, sort of phone avenues, how might that affect some of the processes that we've talked about here, you know, synchrony, visual search, or visual bias, and pain recognition, trust. Do you think that those are processes, you know, that will biases be exacerbated on telemedicine, or, you know, are they likely to be the same?
I think those, you know, are all really good questions. And I mean, I feel like I could make the argument either way. I mean, I've heard some say that because patients are in, you know, a home or more comfortable environment, that might give them some added, I don't know, benefit to being kind of like in a impersonal, austere exam room. On the other hand, you know, you're not, you know, your kind of richness of the communication is going to go down because you're not in person. You can still see faces, but you're not together. So I think, you know, those are empirical questions that need to be investigated. But I think, you know, even moving forward, if we're, you know, I think telehealth is here with us now in a way that it wasn't maybe a year and a half ago. So I think it's important that we start putting our efforts into that, because I think that's going to become the norm for certain patients, regardless of COVID.
Yeah, sorry, I'm nodding, but obviously you can't see me because WebEx keeps crashing. Yeah, so, you know, I wonder, you know, Peter, how about you? Do you think that visual processing of pain expressions becomes more important on telemedicine? I mean, I know I'm asking you to speculate, but I'm just curious your thoughts on that.
Well, it's ironic that you're asking me to speculate that as my video cut out. So, I mean, perhaps there's your answer. There are enough, you know, potential flaws in the system to complicate things even further. I think, yeah, obviously it focuses your attention to, you know, the face, of course, and it makes those cues front and center. So, it's likely that you know, the visual signals, the nonverbal signals that are pain specific or pain related, are being, you know, interpreted by the clinician or physician in that context, and that, you know, bias is being upregulated to some extent as a consequence of that. Again, though, I think uncertainty plays a big role there. Like, what does it mean to give off those expressions in a telehealth environment? What do they mean in that context? How is that pain interpreted? Going back to everything that Paul was saying, how are we potentially objectivizing that subjective data and pushing it in one direction or the other direction based on the biases that we bring to the table? So yeah, just long story short, yes, I think it's obviously going to play a role in the telehealth context as well.
So I have another question about sort of how the dynamics of the interaction might change with various addition and subtraction of variables. So what happens when there is a caregiver in the room? When, you know, someone brings their caregiver, when the caregiver is on the video call, you know, either as a support or as an active part of the process, is there research on how the various, you know, interactions and processes that you've talked about might change in that capacity? Or do you have any sort of speculation about how that dynamic might affect the interaction, the pain evaluation, et cetera?
I think that's a great question. And empirically, I think there is such a limited information about the role of companion and basic research of, like, you know, how implicit bias might manifest in patient provider and maybe even triadic interaction. I think that's really an important question, but one person being added to the equation has so many different variables. So I have to think a little bit more carefully how to answer that question. I don't know if I can formulate my answer in a minute or so.
That's fair. I think that was a good response, though.
Well, I think we know that a companion or a caregiver changes the interaction, just from like an information exchange, question asking standpoint. So they're going to affect it somehow. Non-verbally, one thing that I'm working on with our current R01 is to do the motion energy analysis with 3 people. So the physician, the patient, and the primary caregiver. So we'll start to get some more data on that. But of course, that's a ways away.
One thing I'd just add there, again, I think it's a fascinating and empirical question that we need some more data on at present, but there is completely outside the clinical context, there's some great work in the social psych literature on implicit homophily and how the racial concordance or discordance of, a friend dyad could influence a perceiver's implicit biases. So that, implicit biases, implicit anti-Black biases against a friend get transferred to, against a Black friend get transferred to their white counterpart. So I can imagine race and racial dynamics in the patient caregiver dyad also playing a key role here.
That's a really interesting connection that I hadn't thought about. Yeah. So I have, I guess, a question for all of you that arose kind of during Paul's talk. So all of these talks have been basically trying to understand the dynamics of how a clinician sort of evaluates pain and how they treat it in the context of the interaction and all of the psychological dynamics of sort of and interpersonal dynamics, that contribute to how that occurs. And, Paul made the excellent point that, how much can we know about another person's pain? And, are there really objective ways to evaluate pain, which of course there aren't. And I recognize this is complicated given, the addictive nature of pain meds, and the sort of shared decision-making context where the clinician's evaluation really, does matter in clinically relevant ways. But also it made me wonder if we're missing the larger picture in some way when we're relying on the clinician to evaluate pain rather than trusting the lived experience of the patient, and whether there's a way instead of or in conjunction with considering the leverage points in all these processes on the physician's end, that we could better incorporate patients' lived experience and description of their pain rather than trying to figure out how to objectively evaluate it. I can't tell if I'm frozen or if that's just too complicated a question.
I think
No,
yes,
okay.
because, well, at least I don't have expertise in pain research. So that's a little bit outside of my comfort to answer the question. But I think that's really important. Like as a social psychologist by training, what we care is how we construe our subjective experience. So like why we are not weighing this more when we are looking at pain. And I think that's the disconnect between, clinical like disease and illness. Like we tend to really focus on fixing disease and then focus, minimize it, really understanding the feelings, subjective feelings and experience. I don't know if I can answer your question in a really constructive way, but.
No, I mean, I do think that answers that. And I'm not sure that we have an answer, but it just sort of struck me that we are, coming at this from, how do we improve clinicians' evaluation and construals. But
as I think it is, yeah, it's definitely a thorny and gigantic question, tough to get your hands around. But I've been thinking a lot lately about all the things that those 0 to 10 scales or those faces scales or those types of measures, what don't they incorporate? What don't they evaluate? What don't they ask? And the answers to those things might be the things that you can't do as a result of your pain, the opportunities, the sort of day-to-day things that you're now missing out on. They may be, as I think a number of us, referred to, they may be kind of emotional or existential consequences of that pain. In cancer, it can be the fear of a recurrence, for example, or the fear of disease progression. So, yeah, I fully agree that it's important to consider the aspects of pain that are not being captured by those types of measures or scales.
So I have a question to Paul.
Oh, sorry.
Sorry, I'm talking over you.
Sorry.
So, there are
crashing.
measures
I
like
wanted to.
Oh, it seems like maybe Paul has cut out a little.
Yeah. I was going to say, there are measures like quality of life, like how much certain diseases or illnesses interfere with the daily activities. Like, are there any measures that's looking from the backward, like, how pain is interfering with daily activities, and then try to address those more tangible and as opposed to feelings, if clinically, if there is a resistance to really address subjective feelings.
Paul, are you back? No. Okay, so I'm going to move on to some specific questions for specific speakers that have come up. So one of the questions is, so Peter, how well do you think brief exposures of pain expression generalize to a clinical evaluation context where you're interacting with someone for a longer period of time?
Yeah, fully agreed there. I think in the upshot of that question, I just want to make clear that across our studies, we don't always have very, very rapid presentations of faces. That was really a manipulation used to ascertain the automaticity of this bias and whether it was dependent on explicit, deliberative inspection of those faces, which it doesn't seem to be the case. It is automatic. Then the question, I think, becomes, well, okay, are we overriding that bias, that initial automatic bias, once we have more time and more exposure and more, direct contact with the patient? Some work that we've been doing lately is geared towards motivating our patient or our perceivers to individuate these targets, to think about them as unique individuals, to consider aspects of them or their pain that are unique and individual and specific to them, which obviously those are the kinds of things that would come up in a extended interaction, right? Not just a brief flash of a face on a screen. The story seems to be, so this is work that my grad student Alexis Strain is doing. So she's conducted 4 studies on this so far, and the story seems to be, when you meta-analyze across that data, that motivating people to individuate and really focus on those unique individual aspects of these targets, it has some benefit for reducing bias, but certainly not much. And it certainly doesn't eliminate or reduce the perceptual bias. So I do think that these biases at brief exposure are generalizing to longer contact and longer exposure.
Thanks. That's, I think, really helpful. So another question, and this, let's see, so there are some related questions about the intersection of race and ethnicity with gender. So, you know, a question for Peter is, has your work also examined evaluations of women's facial expression? And, you know, sort of a general question for everyone is to discuss how gender identity as opposed to biological sex might influence, well, I guess this is for Lauren, might influence synchronicity, you know, and how that might intersect with race and ethnicity. So, you know, we've talked a lot about race and ethnicity, but just interested in the role of gender identity.
Yeah, and that's a really good question, and one that I'm anxious to answer. But because we were using, you know, we did a secondary analysis with previously collected data, and unfortunately, we didn't have a very even distribution of male and female patients. And I'm not even entirely sure we collected data on gender identity, or rather just did biological sex. So I think there's got to be, you know, a pattern there. And I know previous research on Synchrony has identified gender differences as well. So I'm anticipating that we'll find something, but I think a lot of that falls on spending more time collecting primary data. Because one thing I didn't really get into was that, you know, using those kinds of, or using that kind of automatic software is great, but it really is better when you have video data that are collected with that in mind, which, you know, the two studies that I used clearly weren't, because we didn't have that software available to us. So I think with a lot of questions that I have, that I think spending some effort gathering primary data would help us to answer, and that is probably one of the first ones I'd want to look at.
And as far as the effects or the intersections between race and genders, target race and target gender, in the context of the perceptual bias I talked about, we have done some fairly extensive work at this point, building gender into the design and the model as well. So this is work that my grad student Azadeh Goharzad is doing. She's run a ton of studies at this point where we show both male and female, or men and women, and black and white faces. And what's really interesting is that this bias and perception is magnified within the male targets versus the female targets. And why might that be? Well, now actually mentioned the work of Phil Goff. Some other work that Phil Goff has done has focused on these sort of the semantic associations between race and gender, and the extent to which male is sort of prototypical of black, while female might be more prototypical of white. And the idea in Azadeh's work here is that, you know, these cues to racial prototypicality are being sort of upregulated within the male faces versus the female faces, and that is magnifying these biases in perception. Interestingly, as far as our treatment component, we don't see that kind of interaction. There we typically see that black female faces are prescribed the least amount of pain reliever overall compared to all other target categories. So an interesting dissociation between perception and treatment there.
Thanks, everyone. So I want to be mindful of the time and sort of wrap things up. I just want to thank all of the speakers and the moderators and the discussants and all of the audience as well for sticking with us through all these technical glitches. We're going to be mindful of WebEx updates and using this platform for future webinars. So thank you, everyone, so much for participating, and we look forward to seeing you at future webinars, and this will be posted on the NCI website within 3 weeks, and the next webinar will be scheduled later this year. And the other webinars in this series are already up on that website. Thanks, everyone.